All right, so here's the rules, folks. I'm a neonatologist. I apologize in advance. I'm not here to teach you clinical neonatology. You're welcome. I know no clinical neonatology. I'm here to teach you what you need to pass the pediatric boards. There are 5 diseases in neonatology. For all of them, you turn the ventilator up when the kid is sick, you turn the ventilator down when the kid is well, and when he cries, he goes to the Well Navy nursery. Or preferably home. No, seriously. So, there are lots of different ways to practice clinical medicine, and what I'm going to tell you today is to just sort of remind you in the deep recesses of your brain what you already know, and this has virtually no clinical application at all. So it's a good, it's a good test review score thing. So if you have any questions, tough. No, stick your little paw up in the air, and I'll be happy to answer them, perhaps. And it's Hawaiian Shirt Day. I am the reason that there is Hawaiian Shirt Day. And the most critical question on the test will be, why does Dan Polk wear Hawaiian shirts? And the answer is, because he can. Where's Ricardo? Ricardo? Ricky? Stand up, Ricky! Oh, you got to stand up, dude. It's a rule. Hawaiian Shorts Day. Very nice, Ricky. Very nice. I understand that there are people wearing Hawaiian prints other places, but we won't go there today. All right, so this is everything you wanted to know about neonatology, and then some for the boards. Here we go. I'm going to define a couple of terms. Live birth is the evidence of life after expulsion and extraction. Isn't that just a beautiful term? And fetal death occurs, obviously, before the baby gets expulsed, with no evidence of life. These are tough. Infant death. The pediatric people define death of an infant as anything that occurs between birth and a year's worth of life. So there you have it. Gestational age. Number of weeks from the first day of the last menstrual period. Now, this has always puzzled me a bit. Because when you are 1 week pregnant, according to this definition, you're not pregnant at all. And when you're 2 weeks pregnant, you may not be pregnant at all. What the hell is up with that? Anyway, I think the Yaya Sisterhood should join in and figure that out. All right, birth weight. Obvious. The term appropriate for gestational age, AGA, is the 10th to the 90th percentile for any given gestational age. That's appropriate. So by definition, 20% of you were born inappropriately for gestational age. Therefore, you get small for gestational age, and you get large for gestational age. And then low birth weight is less than 2,500 grams, and it is not gestationally age dependent. Term birth. This is the most schizophrenic part of the exam. According to the Academy of Pediatrics, in whom we trust. Moment of silence, please. Thank you. When they write the test, one more. When they write the test, term is defined as the first day of the 38th week, day number 260, notwithstanding those 14 days we don't want to talk about. Post-term is you're born on or after the first day of week 43, which for those of you who count days is 295. If you've ever been pregnant, you count hours. Preterm, this is the one that screws people up. Preterm is born on or before the last day of the 37th week. So if you're born, class, at 37 and 2/7 weeks, you're preterm for the purposes of the pediatric board exam. Because in every other part of the universe, English speaking or not, 37 weeks is term. I'm here to tell you that from here on in, between us, 37 weeks is not term. 38 weeks is term. And when the American Board of Pediatrics writes in conjunction with any other medical information people on the planet, they change their mind. But they don't for the exam. I'm done there. A neonatal race, highest in African Americans, lowest in Pan-Pacific Islanders, and in terms of Caucasians, males are the group that die the most. That's why we're precious. Neonatal mortality, maternal factors, those are them. Women who are over 40, if you've been to high school, you're okay. Neonatal mortality, well, all of high school, by the way, and have transcripts. Neonatal mortality, males obviously more than females, multiples and preterms. Those are the ones who tend to die. Preterm risk factors, there they are. The newest one that's been added to the list is bacterial vaginosis, which sounds really pleasant and not something your mother's likely to have told you. Preterms account for about 10% of births, but they account for 65% of all infant complications, yay neonatology, and about 15% of all neonatal deaths. Preterm survival, less than 1,500 grams have about an 85% global survival rate. And 500 grams have about a 10 to 15% survival rate, and that's at about 25 weeks gestation. Those are the numbers that they typically use on the questions. Risk factors for preterm survival. These put you at greater risk of not surviving, okay? So if you're male, if your 5-minute Apgar is less than 4, if you're hypothermic, if you're bradycardic, and if you have intrauterine growth retardation, that decreases your chances of survival. Intrauterine growth retardation, that's being born smaller than what you would predict at an average gestational age. Those are some maternal risk factors. Ethanol ingestion is not the one that we generally think about. What's the leading cause of infant death? This is not a response question. Congenital malformations. So even when we eliminate prematurity, thank you, March of Dimes, there will still be work for me. So, here's an obvious question. You're notified that a newborn has just been added to your service. He was born 20 minutes ago via cesarean delivery at 37 4/7 weeks gestation. Hint, hint. Why does this cause you to put down the phone and shake your head? Your service is not on call. He was not born at term. Since he was born via C-section, he'll be in the hospital for 5 days. Infants born via C-section have less complicated courses than those born vaginally. Very good. Oh, come on. All right, I got bad news. 14% of you are going to flunk the exam. Okay, preterms. Mortality rates are decreasing. Many of you may or may not know that the illustrious King and Queen of Camelot, the President Kennedy, they actually had 3 children, John, Caroline, and a child who was born at 35, count them, 35 weeks gestation at about 6 pounds, who died of RDS. I might point out that he died in the best children's hospital on the planet. Go take that, Boston. So while mortality rates are decreasing, morbidity rates are not decreasing, particularly the big 3, chronic lung disease, retinopathy of prematurity, and intraventricular hemorrhage. The other thing that the Academy has been paying attention to lately, it's like they have like coffee clutches and just dream this stuff up, is the importance of recognizing late preterms. This goes back to our 37 completed weeks gestation, folks. Late preterms have morbidity, that's about 2 to 5 times that in term infants. And the major issues are feeding, management of jaundice, and temperature regulation. So there will be a question about late preterms. Here's some things you need to know about the placenta. On day 6, you're a blastocyst. The outer portion of the blastocyst is the trophoblast. That's the part that invades the uterus and forms the placenta. So trophoblast, placenta. The outer portion of the trophoblast is a complete syncytium. There are no cell walls. And, interestingly enough, no histoincompatibility antigens, or compatibility antigens for that. The innermost surface of the placenta is called the amnion. The next layer is called the chorion, innermost towards the mom, okay? And then organized into cotyledons. These are discrete groups of tissues that are supplied by one artery and one vein. The human placenta is called hemochorial because maternal blood directly contacts the amnion, okay? So amnion, I'm sorry, think what you're reading, Dan. Maternal blood directly contacts the chorion. That's the maternal blood directly contacts the chorionic surface of the placenta. Umbilical cord, 2 arteries, 1 vein. Average length about 55 centimeters. And if they give you a test question about one umbilical artery, think about congenital anomalies in the answer. Most commonly renal abnormalities. Placental abnormalities, chorioamnionitis. Usually from ascending infection of the amniotic fluid. More common 20 to 30 weeks gestation. More common in prolonged rupture of the membranes. And more common following amniocentesis. In accreta, that's when the placenta fails to deliver, but generally can be coaxed out of the uterus. And it's usually an indication of prior uterine trauma like a D&C. Per-creta placentas generally can't be manually extracted from the uterus. They need to be surgically extracted. And these are the ones that cause the increased risk of maternal hemorrhage, sometimes fatal. Abruptio placenta, or abruption, is a clot that follows retroplacental hemorrhage. The most important thing to remember in terms of the test is that that's mom's blood. Chorioangioma is a cause of fetal cardiac failure and another cause of fetal hydrops, of which there are about 150 causes. But placental causes of fetal hydrops is a chorioangioma. Twins. Monochorionic, so-called monozygotic identical twins. They have thin, transparent membranes that you can see through and are not separable. So you can't separate their chorions. Dichorionic, these are separable membranes. These are generally dizygotic twins. Generally is a test question, right? So you can have rare monozygotic twins if the split of the fetuses occurs prior to 3 days of gestation. So monochorionic are always, quote unquote, identical. Dichorionic, generally fraternal, but can also be identical. Twin-twin transfusion is when one twin's artery supplies a cotyledon that's drained by the second twin's vein. If it's severe, it can cause congestive heart failure and hydrops. And there is now antenatal therapy where they can actually cauterize the offending connections. So twin-twin transfusions, generally defined as a hemoglobin that's more than 15% different between the two twins. Prenatal care, what to expect. So dating of the pregnancy. It's good if you're pregnant that you've been dating. History and physical exam, which I think obstetricians still do. And antenatal labs. I think now we're up to virtually every state in the United States doing HIV testing prenatally. And also counseling, what to expect when you're expecting kind of stuff. There's the schedule of how frequently we do prenatal care. So if you get to 36 weeks, 1, 2, 3, 4, 5, 6, you should probably have been seeing your obstetrician at least 6 times. Group B strep, we're going to talk a couple places about this. This is the leading cause of neonatal bacterial infections. So it passed E. coli a while ago. I'm not sure that's a race you want to win. We no longer make the diagnosis of group B strep or the risk factors based on risk factors. So generally, we culture all pregnant women at 35 to 37 weeks gestation. It's important to culture them both vaginally and rectally. That will be a test question. And we give prophylaxis to those pregnancies that are positive. Plus, we give prophylaxis to any woman who's had GBS, group B strep bacteriuria, or has delivered a previous infant with group B strep disease, whether or not she's group B strep positive now. So because those are the outliers, those are the testables, right? So all positives, GBS, bacteriuria, and a previous history of an infant with an affected disease. What do we use for prophylaxis? Penicillin. What do obstetricians use for prophylaxis? Anything that comes off the shelf. If the woman is felt to be penallergic, There are the acceptable alternatives. Notice that it says if she's high risk, she needs to have sensitivities. I'm here to tell you that I've never seen sensitivities run on group B strep, period. And generally, most women just get vancomycin. That's a clinical observation. Who doesn't need prophylaxis? This is testable. If you're screening culture negative, if you're a repeat cesarean delivery with no labor and intact membranes despite being group B strep positive, and if you were previously group B strep positive in a previous pregnancy and now negative, or if you were group B strep positive during this pregnancy and are now culture proven GBS negative. I've never seen one of those either. What happens if you don't have cultures? You look at risk factors for deciding who needs to be prophylaxed. So generally, we prophylax everybody with no cultures who's less than 37 weeks, who has rupture of membrane greater than 18 hours, or who has a fever. No cultures and preterm rupture of membranes. Generally, we culture the mom at that point and start antibiotics as if she were positive. If she turns out to be positive, we continue them. If she turns to be negative, we stop. An expectant mom in your practice has previously delivered an infant whose postnatal course was complicated by group B strep sepsis. She wonders if there's anything that can be done to lessen the chances of this occurring during this pregnancy. So you tell her which of the following. She'll be cultured prior to delivery, and prophylactic antibiotics will be given depending on the culture results. Or, unfortunately, there is no way to lessen the chances that this infant will be infected. Or, she will receive intrapartum prophylaxis on the basis of her history. Or, depending on the sensitivity of the previous infant's group B strep, she may be able to receive intrapartum prophylaxis. I won't sing during this one, because 12% of you let me down. All right, so she will receive intrapartum prophylaxis on the basis of her history. Doesn't really matter whether she's group B strep positive or not. So if you've had a previously affected infant, you get prophylaxed no matter what. Preterm labor is defined as uterine contractions with cervical changes. If you've had a prior preterm birth, it increases your risk. There's a fair amount of discussion these days about whether tocolysis makes any difference or not. And the most important component of treatment during active preterm labor is antenatal steroids. Premature rupture of membranes, expectant versus active management. I love that term because it actually implies that you're doing something. Expectant management, well, that sort of speaks for itself. I expect we'll wait. Active management, well, we're really going to wait. Management of prolonged rupture of membranes in preterms generally depends on what the infant and mother dyad look like. She's febrile, baby's tachycardic, kid's getting delivered, which is the differential diagnosis of everything in obstetrics. Deliver. So not in active labor, not febrile, not tachycardic. I expect she'll deliver at some point. The role of infection management, therefore, is probably one of the critical components. So what we're trying to do is to deliver an uninfected child. Preeclampsia. So that's how we diagnose preeclampsia. Oddly enough, there is no laboratory diagnosis of preeclampsia. It's all clinical. So there are some clinical signs or symptoms. In severe disease, we give magnesium sulfate. But generally, much like many problems in obstetrics, the management of preeclampsia is delivery. Maternal diabetes, mellitus, can lead to an increased frequency of congenital anomalies. Those congenital anomalies, however, are not related to the control during the pregnancy. They're actually related to your preconceptual glucose control. So we're looking for hemoglobin A1Cs of less than 6 at the time of conception, which we know happens 2 weeks after you're pregnant. And then the whole issue of fetal macrosomia and neonatal complications thereof. How do we measure fetal well-being? Well, one of the ways that the American Academy of Pediatrics still thinks we measure fetal well-being is in fundal height, particularly in diagnosing intrauterine growth retardation. I'm here to tell you that every woman in the United States has at least 2 ultrasounds. Or if you happen to have good insurance, 26 ultrasounds. So, well-being as guided by ultrasound, generally done at 20 weeks gestation. And a level 1 ultrasound consists of measuring the biparietal diameter, looking at head circumference, abdominal circumference, and femur length. So level 1 ultrasounds are measurement ultrasounds versus level 2 ultrasounds, which cost twice as much, which is why they're called level 2. No, they look for structure of issues like structure of your ventricles, structure of your heart ventricles, structure of your liver, structure of your vertebral column, those kinds of things. Other tests of well-being, non-stress tests, so it's defined for you there, or contraction stress tests. Remember that you can use spontaneous contractions to do contraction stress tests if you so desire. And what we're looking for is the absence of either decelerations or late decelerations. Biophysical profile. So this is when you use ultrasound to look at those 5 things: movement, tone, reactivity, breathing, because there ain't no gas in there, and amniotic fluid volume. Assign a score, and generally scores of less than or equal to 4, consider intervention, and intervention would be, I love it, you might want to take the OB exam the next day. Modified biophysical profile, you should look at this and think lazy. You divide the amniotic fluid chamber into 4 quadrants and measure volume. And what you're looking for is those kind of numbers. So if you're less than a total of 5 centimeters of detectable pockets of amniotic fluid, you got oligo. Between 5 and 24, that tells you there's a lot of variability. It's normal, and greater than 24 centimeters generally indicates polyhydramnios. So that amniotic fluid index plus a normal stress test is a modified biophysical profile. Fetal heart rate monitoring. What is it? Simultaneous measurement of fetal heart rate and uterine contraction. So it really should be called fetal heart rate / contraction monitoring. How do you do it? There's a couple different ways. Note that people think that auscultation every 30 minutes in the first stage and every 15 minutes in the second stage is perfectly acceptable. And I'm here to tell you that I'm on their side. Want to know why? Because fetal heart rate monitoring has never predicted jack. So it doesn't predict those kids who necessarily need cesarean deliveries, although it leads to a lot of them. It doesn't predict those kids who have poor outcomes. It doesn't predict those kids who need resuscitation. It doesn't predict those kids who need Apgars. It doesn't predict those kids who need cerebral palsy. It doesn't predict those kids who need neonatal intensive care unit. It doesn't predict jack. It predicts you getting up in the middle of the night. Fetal heart rate patterns, the so-called non-reassuring. Why? Is that because sucky doesn't sound like a good diagnosis? How are the fetal heart rate tracings? They're non-reassuring. So there you have them. Saltatory means jumping. Variable deceleration, late but with good beat to beat. Now, that's an obstetrician who's got soul. Ominous fetal heart rate patterns. Ominous. Ominous is when you see the nurse running out of the room. That is the definition. So persistent late decelerations. Late decelerations are those that continue past the uterine contraction with no beat to beat. Variabilities with no beat to beat reactivity, and then you see the rest of them. And then if just you lose your beat to beat. What do? The American Academy of Pediatrics feels that we do scalp pHs. I haven't seen a scalp pH done since 1996, I think, something like that. But those are the values, less than 7.2, what do? There you go, I love it. And if it's an ominous pH, the liver, there you go. Fetal heart rate patterns, what are some causes of severe bradycardia in fetuses? This is important to recognize because perhaps delivery is not the best thing at that point. So prolonged cord compression, that sounds like a delivery. Tetanic uterine contractions, that sounds like you back off the pit. Paracervical block, talk to anesthesia. Maternal seizures, now there's a differential diagnosis. Look at the fetal heart tracing. Look at the mother! Rapid descent of the fetus or a vigorous vaginal exam. Double yikes. Oh, Dr. Shelverstein. Whew. So, fetal heart rate, decelerations, early decelerations mirror the uterine contractions, are generally felt to be due to head compression. Late decelerations generally recover only after the uterine contraction subsides and are felt to be a symptom of uteroplacental insufficiency. And variable decelerations are generally felt to be due to cord compression. I always thought variable contractions were those that you couldn't either put in early or late. So, cesarean section, indications. I did not put obstetrical impending vacation here, but it could go under other. So, a previous C-section, generally in the United States, sentences you to a second C-section or a third or an eighth. Dystocia, fetal distress, malpresentation, and the proverbial other. I work in a hospital occasionally in the Chicagoland area that will not be mentioned, but it's in Lake Forest, where the median income is, I don't know, billions. And about 15% of our cesarean deliveries up there are mother scheduled. This from the woman who thinks that she was pregnant 2 weeks before she actually got pregnant, but never mind. Cesarean delivery, as we increase the rate, we increase the cost, and we increase maternal morbidity. Vaginal births after cesarean are virtually taboo these days, but occasionally you'll find some family medicine person who will love their. I really don't understand why we don't do more VBACs, but I'm not an obstetrician. Operative vaginal deliveries, vacuum. I love vacuum deliveries. They never work. But the cool thing about it is that when you're on call and they call you for a vacuum delivery, you know you got time. Because nothing's going to happen. Except the damn vacuum's going to fly off. So it's generally good not to be in the direct path, because you're going to have to change your scrubs. Forceps delivery. Whoa, get out the salad tongs. So obviously these kinds of operative vaginal deliveries can be associated with neonatal trauma. Station. So station of an operative delivery is defined as the number of the centimeters the head is either above or below the ischial spines. Those are her ischial spines. If you have your head above or below your ischial spine, you've got another problem. So mid-outlet delivery, or mid-forceps or mid-vacuum delivery is 0 to 2 centimeters, now below the ischial spines. Generally, we don't go for operative deliveries above the ischial spines unless we're in, like, Pango or somewhere. +2 to +4 is a low operative delivery, and outlet is when the head is at the pelvic outlet. All right, now we're going to talk about fetuses. So we're going to talk about fetal transitions. The first organ systems we're going to talk about are circulatory. So remember that for the fetus, it's getting its oxygen not obviously from its lungs, but from its mother's placenta. And so the oxygenated blood starts on the venous side of the fetus, particularly the umbilical vein. It's characterized, circulatory transitions are characterized by the presence of fetal shunts. So there's ways to get that oxygenated blood from the right side of the heart to the left side of the heart. The fetus is a right ventricularly predominant organism, unlike most of us who are left ventricularly predominant. So the pressures are actually higher on the right side of the heart than they are on the left side of the heart. And pulmonary hypertension is normal in a fetus. The fetus is attempting to shunt blood away from this relatively disused organ by the time when you're a fetus. But by the time you're a newborn, that organ becomes relatively important. So normal fetal circulation, we talked about the fact that gas exchange occurs down here by the placenta. So oxygenated blood goes up the umbilical vein, and then through the ductus venosus, and then into the inferior vena cava. And then the first shunt is across the atrium through the patent foraminal valley, and that's how the majority of oxygenated blood ends up on the left side of the heart. There's also a second shunt where the pulmonary artery shunts blood through the ductus, which is that little structure that attaches to the aortic arch. So right ventricular output is maintained by right to left shunts across the foraminal valley and across the ductus arteriosus. So what happens during normal transition? So let's pay attention over here. During fetal life, pulmonary artery pressures are high, pulmonary blood flow is low, because pulmonary artery pressures are high, and fetal oxygen tension is low. So I want to talk for a second here, because this brings up another point. So the normal PaO2 of a fetus within 10 is what? It's here. There's a clue. 20 is a good number. Yeah. About 20. What would happen to you if your PaO2 were 20? You'd be dead. Simple. Why aren't fetuses born dead? Well, it pisses their mothers off first. Why can they sustain PaO2s of 20? Fetal hemoglobin. Thank you very much. So fetal hemoglobin loads and unloads at lower partial pressures of oxygen. So you're about 70, 75% saturated at PaO2 of 20 if you're a fetus. So that's a good thing to remember. So that is characterized what the normal fetus looks like. In the newborn, pulmonary artery pressure falls, pulmonary blood flow rises, and subsequently oxygen tension rises in the newborn. What happens when you don't adequately transition appropriately? You have persistent pulmonary hypertension. The clue is in the name. So your hypertension in your pulmonary persists. Okay? So it's not rocket science, which explains why I'm a neonatologist. So your PA pressures, instead of falling, stay high. Your blood flow stays low. And your oxygen tension doesn't do anything at all. Also stays low. So you continue to use your fetal shunts, and you don't oxygenate or perfuse your lungs. So that's the bad transition in fetal circulation. How about respiratory transition? So the fetal lung, fluid-filled. When you breathe, you increase your compliance, so you make your lungs more compliant. That increases the surface area, and because now you've got probably between 5 and 10 times more surface area in your lungs than you did before you were born, you increase your oxygen carrying, or your oxygen diffusion. You have to clear your lung fluid, which happens via an active sodium pump, and you establish your functional residual capacity. And there, folks, is where the magic of surfactant happens, in establishing your FRC. It avoids the end expiratory collapse of your alveoli, and therefore, much like a stretched versus a non-stretched balloon, it becomes easier to inflate your alveoli because instead of having to start from ground zero with each inspiration, you've got a functional residual capacity, so you've got air left in your lungs. And since it's easier to blow up a balloon that's already partially blown up than it is to blow up a balloon that's not blown up at all, the child doesn't have to expend as much respiratory effort and doesn't go into respiratory failure. So, what about glucose transition? So in order to be able to appropriately transition as a fetus for your glucose, the fetal glucose supply is originally maintained by placenta. So while there are glucose transporters, roughly the amount of glucose that's going into the fetus is proportional to the amount of glucose that's in your mom. And the brain of the fetus exclusively uses glucose as fuel for metabolism. So under normal circumstances in the fetus, there's very little glycogenolysis and virtually no gluconeogenesis. So all of your glucose is coming transplacentally from your mother. So obviously, in order to be able to transition, you've got to both be able to break down glycogen as well as make glucose from other sources. That's not being done when you're a fetus. What about fetal transition for water balance? So term infants, about 80% water and about 20% trouble. 2/3 of that water is intracellular, And normally we expect about an 8 to 10% loss in the weight in the first week. That's mostly intracellular or interstitial water. And that amount of weight loss is exaggerated following preterm delivery. So the loss of 8 or 10% of your body weight in the first week at term is normal. Let's ask a question. Okay, Dan. Fetal circulation is characterized by A, high left ventricular output, B, pulmonary hypertension, C, similar anatomy to that of newborns. If anybody answers C, I'm going to strike you dead. And D, separation of the right and left-sided circulatory systems. Very nice. You're doing it just to jack me around, aren't you? Let's talk for a second about Apgar scores. Apgar is not an acronym for something. It was actually someone's name. Her name was Virginia. Her name was Virginia. Virginia Apgar. Virginia Apgar has two claims to fame besides the Apgar. She's the first woman physician who ever appeared on a U.S. stamp. That will not be on the test. And she wasn't a pediatrician or a neonatologist. She was an anesthesiologist. The only good thing that anesthesia... Well, never mind. So Virginia had a plan, and her plan was that she was going to come up with some sort of system that would predict infants who needed resuscitation. Now, that's anesthesia thinking. Not anything else, just resuscitation. Do I have to go? Don't I have to go? So she developed the Apgar score. There it is. You will be given a clinical scenario for which you have to derive an Apgar score. So generally a good thing to look at. What does the Apgar score predict? Not much. It predicts a kid who may need resuscitation, which is what Virginia wanted to do. But Virginia's model's got a couple problems. When does one assign the Apgar score? This is not a trick question. 1 minute and 5 minutes. So, okay, you're in the delivery room. And the kid comes out blue, limp, cyanotic, and no respiratory effort. You say, 1 minute, please. All right, so at 1 minute, you do your magic. And then what? Stop? 5 minutes, please. So it's not subtle. And it certainly doesn't predict cerebral palsy as well as anything else. It predicts something that you're going to have to write down on a form. So these days, we don't let babies go 1 or 5 minutes before we decide whether or not we're going to resuscitate them at all. And whether you're born with Apgars of 8 and 9 or 5 and 7 probably has absolutely no implication in your later life. So let's talk a little bit about neonatal resuscitation. So these are the sort of shortcuts that you need to know about resuscitation. This will not get you through the neonatal resuscitation program, which these days takes about a month, because you got to do the exam and you got to look at the disc and then you got to find an instructor. It's painful. If your baby is born cyanotic with a heart rate greater than 100 and breathing, yes, then the baby needs free flow oxygen. If you're cyanotic, your heart rate is 100 or greater and you're breathing. If your heart rate is less than 100, whether you're breathing or not, you need ventilation. And that's kind of the key of neonatal resuscitation. It all depends on ventilation. People get freaky about the fact that the heart rate's low and want to do something freaky, like chest compressions or, God forbid, epinephrine. The key to raising a heart rate in a newborn in the delivery room is ventilation. Ventilation would be the key to raising the newborn's heart rate. The heart rate would be the indicator of the need for ventilation. Can I say it any other way? Ventilation is probably important. So you're looking for a chest rise, and you want to be given the breast at about 40 per minute. At that point, generally, I need to remember that my respiratory rate is going to be higher than what I need to give the baby. And the goals are sats in the 90 to 95% range. If your goal is a sat between 90 and 95%, how does one recognize whether one has achieved this goal? A pulse oximeter. Excellent. Because I defy you to clinically tell me by exam whether the kid is 90 or 95% saturated or 87 or 98. So it would be helpful to have a pulse oximeter. And actually, neonatal resuscitation these days says you have to drag one with you. What about endotracheal intubation? Tube sizes. They'll ask you this question. So less than 1.5 kilograms, 2.5 millimeters, 1.5 to 2.5 kilos, 3, greater than 2.5 kilos, 3.5. And your weight in kilograms plus 6 gives you the lip to tip length tip of the endotracheal tube. I'm not going to do that. So what about if you have a sustained heart rate of less than 100? If what you're doing isn't working, consider the following possibility. You've screwed up. I like people who never consider the possibility of screwing up. It shows that they have good, self-feelings. But they inevitably screw the kid up. So check your previous steps, particularly class, begins with a V, ventilation. And if in your previous steps you're absolutely certain that everything is okay, then we start cardiac compressions. Drugs for neonatal resuscitation. These are the drugs that the American Academy will test you on. Epinephrine, there's what it does. It enhances contractility, increases heart rate, as well as arterial constriction, thereby increasing blood pressure. What are the doses? There they are. And in its merciful wisdom, the Academy of Pediatrics has decided, for a while they thought that endotracheal instillation of your epinephrine was as good as intravenous, and now they've backed off of that. And so now they would prefer that you give it intravascularly. They would prefer that you give it intravascularly into whatever vascularity you can give. But generally in the delivery room, it's the umbilical vein. You don't have to be pretty about this. All you got to do is put some tube of some sort into the umbilical vein far enough that you get some blood back. It's about that big, that far. Feeding tube will work, catheter will work, I suppose a big angiocath would work, anything. And then you give your drug. So it doesn't have to be above the diaphragm, doesn't have to be in the heart, doesn't have to be anywhere else. And they've backed away from the idea that endotracheal instillation is equal to the efficacy of IV infusion, and now suggest that if you're going to give it endotracheally, you give it until you get a response. So perhaps as much as 10 times the dose. I'm here to tell you that at this point, general pandemonium and panic have ensued. And figuring out 10 times anything becomes a difficult prospect. You'd think adding a 0 onto something would be easy. So virtually, if you're giving it endotracheally, you cannot overdose the kid. Bicarbonate. In order to be able to give bicarbonate during a neonatal resuscitation, you need 2 things. Proof of a severe metabolic acidosis, which implies blood gas, good, and effective ventilation, because it doesn't work if the kid's not being ventilated. There's the dose. Resuscitation, glucose. So people don't think about glucose. They think about epi. They think about bicarb. Sometimes they think about calcium, which is really funny. But glucose. So again, useful to determine a level. And the thing we want to avoid is high swings in glucose. So we don't use concentrations higher than D10. And we give it by continuous infusion if we can. Naloxone. Naloxone's a narcotic antagonist. There's the dose. But you need to think about 2 things when you're giving naloxone in the delivery room. The first is, could this mom be a chronic opiate abuser? Because giving naloxone to a fetus from a woman who's a chronic opiate abuser will precipitate the most beautiful withdrawal that you have ever seen in any human individual, with seizures and hypertension. It's just lovely to watch. So you don't want to be giving it to women who are chronically abusing opiates. And you also have to consider the fact that if you're giving it, whether the half-life of the naloxone, which is generally a couple hours, is appropriate for whatever narcotic you're trying to reverse. Because I have seen children get naloxone on delivery, perk up, because they're happy campers now, sent to the normal newborn nursery where they promptly die because the naloxone wears off faster than their opiate that they were exposed to. So the one that's the biggest offender is methadone. So methadone has a half-life of days. So again, those are some concerns about naloxone treatment. Dopamine, generally given for hypotension that's persistent. Again, by the time you get to dopamine in the delivery room, you should be somewhere else, folks. Or cardiomyopathies. There's the dose. Volume expansion. This is given, obviously, when there's suspected blood loss. But remember that most of the time when you're in the delivery room and there's suspected blood loss, it's abruption, right? Whose blood is the abruption? Correct. So we don't want to go running around giving babies blood or volume when, indeed, it's their mothers that need the volume. And a saline is just about as efficacious as blood is. But I'll give you two little hints here, or little gems. The first is that if you've got O-neg, type blood in the delivery room because you were having it for mom, you can use that for the baby. There's no rule. And the second is the placenta has baby's blood in it. It's the baby's blood. It doesn't need to be typed, screened, or anything. So if you're in a pinch, you can take blood out of the placenta and give it to the baby. Now we're going to talk in general about newborn exam. We're going to go through a variety of different systems. So in general, a newborn exam is dynamic. It includes interactions between the baby and the caregiver. So I like to do newborn exams at the bedside of the mother. The American Academy of Pediatrics wishes you would do them there as well. Having said that, 99.74% of all newborn exams are done in the nursery or the delivery room. First exam within 24 hours. First thing we do, or one of the first things we do in newborn exam is gestational age. We've got all these physical characteristics. I'm going to go through them all relatively quickly. My advice to you guys would be to pick two of those physical characteristics that you like and memorize those because they all track together. And when they give you the question about establishing gestational age, they'll give you physical characteristics in all of those systems. So if you know two, you know five, okay? So lanugo is that fine hair present over the entire body less than 32 weeks and gone generally after 42 weeks. It leaves the shoulders last. This is all in your notes, guys. Genitals in the male, testes in the canal with few rugae on the scrotum. That's a pretty wide variation there. And a pendulous scrotum at 42 weeks. Genitals on the female, prominent clitoris at 30 weeks, and then labia majora covering minora at 40 weeks. Foot sole creases is one of my favorites. So none between 24 and 31, a couple between 32 and 33, more than a couple between 34 and 35, two-thirds of the foot covered between 36 and 37, and all the way down to the heels by 41 weeks. I like it because it's smaller. They have smaller jumps in them. Breast buds. There's breast buds. Ears is my second favorite. So flat between 24 and 33, an upper in curve at 34, an upper two-thirds of an in curve after 36, and well-defined in curve all the way to the earlobe at 39. Cartilage, soft, stays folded, versus firm and erect cartilage by term. So here's an audience response question. During a newborn exam, you notice the infant is entirely covered in lanugo, has no foot sole creases, has flat, soft ears with no recoil, and no breast buds. The gestational age of this infant is very nice. Thank you. So newborn exam, those are the kinds of things that we generally would be careful about noting. State. This does not mean Texas versus Illinois. State is awake, alert versus crying versus asleep. And then particular differences in cries versus hoarse and shrill, those kinds of things. Temperature. One of the huge issues that comes up in terms of temperature is fluctuation, and whether it's a real, quote, fever, unquote, or environmental. And sometimes axillary versus rectal differences in temperature can get you that information. If the kid has a fever and the axillary temperature is higher than the rectal temperature, the child is on his way to medium rare. So he's being roasticated. If, on the other hand, the rectal temperature is higher than the axillary temperature, it's probably real. So hypothermia is as an important accompaniment to neonatal sepsis as hyperthermia. And so don't be fooled when they give you the question on the test about the potentially septic child when the child's temperature is 95.6. Skin. It comes in different colors. They will ask you about those colors. Central versus acral cyanosis is normal. Acral cyanosis is the distal extremities being blue, normal in a newborn. And then this question comes up not infrequently. Got a red kid who's polycythemic. When you have a polycythemic kid, you think about children who are unrecognized infants of diabetic mothers for reasons that we'll talk about in a minute. And then obviously the yellow kid, you always wonder about bilirubin metabolism and levels and that kind of stuff. Blisters, aplasia, where you have a patch of undeveloped skin associated with trisomy 13. I would think that there'd be other things present there as well. Subcutaneous fat necrosis, which is common in newborns, a little area of what looks like deep blue or purple discoloration. It's firm, and in some kids it's painful. And then there's all those baby bumps. That's what I call them. Head shape, sutures you want to palpate, make sure there's no craniosynostosis. And an anterior fontanelle is present in virtually every newborn baby, and a posterior fontanelle in about 15%. But you start seeing big anterior and posterior fontanelles, start thinking about things like hypothyroidism. Caput, so a baby who's been in labor for a long time, or a baby who was instrumented, particularly vacuumed, particularly vacuums flying off, tend to have caput. That caput extent crosses across suture lines of the head versus a baby with a true cephalohematoma, where they generally don't cross the suture lines of the head. Some kids with really big occipital cephalohematomas may distort their head archaeology, or I'm sorry, distort their head structure to the point where they actually seem to cross the head sutures. So you can be fooled in a kid with an occipital cephalohematoma. Subgaleal hemorrhages are generally lots of volume. So those are the kids that need to be followed for a while. And then you've got different kinds of skull fractures. The linear skull fractures are actually quite common. And when you have them in association with forceps, the obstetrician gets really nervous. But I'm here to tell you that linear skull fractures happen in non-instrumented babies. But the depressed skull fracture, and particularly basal occipital skull fractures, need somebody with like neurosurgeon after their name to see them. Intracranial hemorrhages, these are also more common than people think they are. Subarachnoid generally can be observed. They're generally found in association with kids who have either an abnormal neurological exam or a seizure in the immediate newborn period. But I'm also here to tell you that we did serial CT scans back when you could do this kind of stuff in babies, and we did 100 kids, and we found subarachnoid hemorrhages in about 30 of them that had absolutely no abnormalities whatsoever, small ones. Epidural hemorrhages, they can be either arterial or venous. The arterial ones are the ones that give you the most problem. Subdural hemorrhages, they can have persistent effusions for the first couple of months after they're born. So those are the ones that sometimes get picked up on a cranial ultrasound later on in their first year of life. Diagnosis, because these hemorrhages are pretty close to the surface of the skull, they generally are better diagnosed with imaging that looks like MRIs or CTs rather than with ultrasounds. You can miss particularly small subarachnoid hemorrhages with an ultrasound. So if you suspect a hemorrhage in an infant, better to image them than to ultrasound them. Eyes, those are the things that you need to be able to do. Horner syndrome, ptosis, so a lid drop, meiosis, a small pupil, and enophthalmos, eye that appears a little bit more sunken. They sometimes ask questions about the triad of Horner syndrome. You should be able to fix on objects and follow as a newborn. You're looking for things like proptosis, hemorrhages, conjunctivitis. And then the ophthalmoscopic examination. Red reflex, which is normal. White reflex, which can indicate either retinopathy of prematurity, so you have to have been premature in order to be able to diagnose this, right? And retinoblastoma is a white reflex. The so-called black reflex generally indicates a cataract. Ears, preauricular pits and tags, they're common. Unilateral, they generally don't have any other associations. Bilateral sometimes can be associated with renal abnormalities. And if you have low-set ears, you think about syndromes as well as urogenital anomalies. Low-set ears is when the insertion of the ear occurs below an imaginary line that you draw from the outer canthus of the eye back towards the ear. Some kids with very deformed skulls because of their birthing process will seem to have low-set ears in the first couple of days of life, and then sort of everything unmolds. Nose, stuffiness of the nose classically is neonatal syphilis, but also in these days can indicate narcotic drug withdrawal. Choanal atresia is important because bilateral choanal atresia kids can't feed, because kids who are breastfed are obligate nose breathers because there's nowhere else for the gas to go. So if you have a kid with bilateral choanal atresia, or sometimes even unilateral choanal atresia, they'll present as feeding problems, not as respiratory problems. Mouth, important to feel inside the oral cavity because sometimes hidden clefts you can't palpate. So, or you can't see, you need to palpate. Tongue, you have a protruding tongue on the American Academy board exam, you have Down syndrome, you're hypothyroid, or you have Beckwith-Wiedemann. If you have a protruding tongue and hypoglycemia, you have Beckwith-Wiedemann. If you have a protruding tongue and big posterior fontanelle, you have hypothyroid. If you have a protruding tongue and general tone issues, decreased tone, you have Down syndrome. I'm here to tell you there's a few other things you could have, but as far as the exam's concerned, that's it. If you have a protruding tongue with a small mouth, plus or minus a cleft, you have Pierre-Robin sequence. You can have supernumerary teeth, so a tooth that's present at birth. Generally, they're very, very fragilely inserted and can be removed by looking at them. What you want to be careful about is removing an actually true tooth. So if it doesn't come out after you look at it, don't mess with it. Neck, masses. Most commonly in the midline is a goiter. We don't see goiters in the United States very much anymore. Towards the, away from the midline or towards the left or right, I can do this, I really can, is a cystic hygroma. Less commonly are brachial cleft cysts. They tend to present more posteriorly in the neck. Or a child who has a preferred way to hold their head, either left or right, with a shortened sternocleidomastoid muscle, that's torticollis, and they look towards the side of the abnormal muscle. So looking left, it's the sternocleidomastoid on the left. It's important because physical therapy and that kind of stuff are used to take care of that problem, and if you don't know which side you're physical therapying, at least your physical therapist ought to know. Clavicular fractures, you can usually palpate them. Supernumerary nipples, so generally along the milk line from the axilla down to the areola. Breast hypertrophy, common both in boys and girls because of the increased amount of estrogen and progesterone that have been around for the last 9 months, or 8 3/4 months, depending. And sometimes they'll even lactate a little bit so-called witch's milk in boys anyway. Lungs, so those are the kinds of things we want to be able to demonstrate and look for in a neonatal exam. Asynchronous movement, start thinking about things like what? Pneumothorax. Coughs. Generally, newborns don't cough. So you have a kid with a persistent cough, start thinking about aspiration and those kinds of things. Hearts. Those are the kinds of things we look for in terms of hearts. Bradycardias. Those are on the differential diagnosis. So many kids will have bradycardia during sleep. It's important to look at their ECGs to see whether they have some sort of heart block. But again, a kid with a protruding tongue, a big fontanelle, and a low heart rate has hypothyroidism. Tachycardia. We think about fevers and hypovolemias, but arrhythmias can be common, particularly tachyarrhythmias are more common in babies than bradyarrhythmias are. Every baby on the planet has a murmur at some point in their postnatal life because they all, at least theoretically, close their ducts. And so when early, late, the type of murmur, whether they're systolic or diastolic, those are all important issues. And when I hear a baby with a murmur, I look at other things. I look at tachypnea, I look at blood pressures, I look at the time of after birth. So murmurs that are persistent, murmurs that are associated with abnormalities in cardiac function, those tend to be the murmurs that should be worked up. And particularly I think about pulses, particularly above and below the diaphragm, because the ones that will get you in trouble are the ones that are ductal dependent. So important to be able to palpate those pulses. Abdomen, those are the kinds of things we look for. On the exam, if you have delayed cord separation, generally more than 10 days, those are kids who have phagocytic defects. So abdominal wall defects, the ones that they'll talk about on the exam, are gastroschisis versus an omphalocele. So a gastroschisis is an interruption of blood supply, generally to the right of the abdomen, and the defect is the hole in the abdomen, and then the intestines come out the hole. So it's generally sided, generally does not involve the umbilical cord, and generally a later in gestation phenomena than an omphalocele. Omphalocele is the failure to return into the abdominal cavity of the rotating, or actually counter-rotating, intestines during gestation. So you all remember during fetal life, the intestines spend some period of time outside the abdominal cavity, do a 270-degree counterclockwise turn, and then come back. One of the miracles of God. If they don't migrate completely back into the abdomen, that's an omphalocele. And the important things about omphaloceles versus gastroschisis for the board exam are syndromes. Syndromes are more associated with omphalocele and not associated with gastroschisis. So a kid with omphalocele needs a further workup. A kid with gastroschisis, that's an isolated defect. Genitals, those are the kinds of things that we're looking at. Because females are hyperestrogenated at the time of birth, you can generally see their hymens. And these days, because of legal issues, I generally chart that they have one. Male, poor guy, if your penis is less than a 2.5 centimeter stretch, you're getting an endocrine workup. Hypospadias can occur anywhere along the penis, but generally they're staged according to where on the penis they occur. And an undescended testicle is not generally a big deal. 2 undescended testicles where you can't feel them anywhere is a huge deal, because those may be masculinized ambiguous genitalia. So if you can't palpate the genital, you can't palpate the testicles in a boy, that kid needs to be seen by an endocrinologist. Anus, if you don't look for it, you ain't going to find it. I won't tell that story either. So many children born with imperforate anuses actually have external fistulas, so they'll still poop. They just don't poop out of the correct hole. And in females, they can have sort of urogenital sciences, so they can poop out of their vaginas as well. For purposes of the pediatric examination, this is not true clinically. For purposes of the pediatric examination, am I got your attention? If you have some kind of meconium obstructive process in your gut, you have to think about cystic fibrosis. So I'm here to tell you that that's not necessarily true, but if the exam says a baby's born, has slow to stool, gets a enema, and they get a meconium plug out, you need to work the kid up for cystic fibrosis. Actually, what you should be working the kid up is for hypothyroidism, but cystic fibrosis, hypothyroidism. Back exams, pilonidal sinuses generally bring up a fair amount of discussion. If you can see a base to the sinus, you're okay. If you can't see a base to the sinus, then something else has to be done to work that kid up. If you have a midline tumor in your back, it's generally a teratoma. Extremities. So a couple of things to point out here. If you have supernumerary digits more than 5, first of all, make sure you're close to a pool. The Olympics is beckoning. But axial supernumerary digits are the ones that are more concerning because they tend to be associated with other bony abnormalities. So thumbs and great toes. If you have extra digits medially to those things, you got issues. Postaxially, little fingers, little toes aren't as serious clinically. Palsies, herbs, and clumpies, the difference between these are upper extremity palsies associated generally with shoulder dystocias or brachial plexus injuries. The difference between an herb and a clumpy is involvement of the fingers. So clumpies have involvement of the fingers, herbs don't, and that will be a question. I don't know why, but obviously either herb or clumpy are still alive somewhere. Ortolani and Barlow maneuvers are looking for dislocated hips. So Ortolani is to dislocate an undislocated hip, and Barlow is to relocate an already dislocated hip. But they'll ask the question generally, they'll give you a bunch of terms and ask which ones are associated with hip dislocation. Limbs, hypertrophy, symmetry, phycomyelia, which is shortening of the limbs, amniotic band syndrome, where you have disruption of a limb. Amniotic bands are usually pretty easy to figure out because they're generally not symmetrical. So you'll have generally what looks like an amputation of some extremity part. So either a leg or an arm or a foot or a finger, depending on where the band wraps. And it acts like an antenatal tourniquet and interrupts the blood supply to what happens distally. Very, very striking when you see them, but not associated with syndromes, not inheritable. So if you've got to have a limb abnormality, that's not a bad one. Newborn exam. Clonus can be normal in newborns, a couple of beats of clonus. These are the general unique neonatal maneuvers. They generally don't ask you about defining them. They generally ask you whether or not they persist. So these generally are present only in the first couple of days of life. Primitive reflexes, same deal here. These are reflexes that generally go away over a period of time. The one that's most talked about is generally the Moro. In order to have a complete Moro, you have to bring your arms back to the midline. So you hyperextend the baby's neck. You then get rid of the hyperextension. The baby has outward extension, but that's not a complete Moro. You have to come back to the midline. So I've seen questions that look like that. Autonomic walking is that stepping reflex that Dad thinks is so cool, where you just brush the baby's feet up against a horizontal surface and the kid will take his foot and put it on. That only sticks around for a while. Obviously, suck-swallow reflex is a rather important one. Eye prophylaxis, vitamin K, hepatitis B, cord care, circumcision. Those are all neonatal issues that generally get discussed. In the United States, there's no medical indication for routine circumcision, according to the American Academy of Pediatrics. Cord care, these days, general pediatrics, the Academy doesn't care what you put on the cord. It would prefer you put nothing on the cord. I always like that purple stuff. Hepatitis B, generally given in the first days following delivery. Vitamin K, obviously, for blood clotting issues, and eye prophylaxis, again, generally in the delivery room. Neonatal screening. So there's a whole bunch of neonatal screens. The thing I want to talk to you a little bit about is, so glucose. This is the hardest thing that I can't talk about clinically because I have my own incredible biases about this. But generally, the definition of hypoglycemia in a neonate is 40. Less than 40 milligrams per deciliter defines neonatal hypoglycemia. And again, it's important in kids whose mothers had diabetes or other issues, the kid was resuscitated. Those are all kids that are at risk for neonatal hypoglycemia. Hematocrits, looking for anemia, polycythemia. Inborn errors of metabolism as well as hemoglobinopathies, commonly referred to as a PKU test, but they test for 20 or 30 things these days. You have to have a degree in genetic metabolic diseases in order to interpret an abnormal screen. However, they just put okay, 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 okay. Hearing, generally otoacoustic emission screening, followed by a complete ABR if they don't pass. There's a fair number of states with political neonatal screening issues because the senator from that state has a child with some rare and unusual disease. Some common problems in neonatal screening are these two. Timing after delivery. And so, in general, we used to wait 24 hours after the baby was born in order to do the neonatal screens. That's not as critical anymore as it was before, because generally we look for the actual defect rather than from the byproducts of that defect now. So, for example, in order to be able to diagnose galactosemia, you don't have to have the baby feeding anymore. But it's important to look at what the time of collection was when you get an abnormal screen back. And then transfusion. Transfusion obviously can alter the population of red cells that's present. So if you have a neonatal test that depends on red cells in order to be able to make the diagnosis, you'll be diagnosing the disease in the person who gave the blood rather than the baby. So you generally need about 90 days after a transfusion to repeat a PKU in order to make sure that it adequately reflects what the baby's conditions are. That was funny. Wow. Multiple births. Obviously, there's an increasing incidence. About 2% of all births. Why? First of all, we have older moms getting pregnant, and as well as the assisted reproduction. Generally, for both of those categories, the older moms and the assisted reproduction, those are dizygotic twins. Risk depends on what the prenatal care has been. The multiple births, their risk of abnormal outcome increases with preterm birth, and then increases with all the other things that increase birth risk. Malpresentation, cord problems, congenital anomalies. 85% of triplets are born preterm. We love them. Operative deliveries, conjoined twins, 1 in 50,000. Those are monoamniotic, so they're monozygotic twins. Fetal growth restriction. The reason we bring these sort of things up is that they can be certainly much more common in kids with multiple births, and they begin to run out of intraamniotic space at about 30 weeks. So 2/3 of triplets are born fetally growth restricted. Small for gestational age. IUGR is actually decreased fetal growth rate. In order to have a decreased fetal growth rate, you have to have two measurements. And remember, these terms, low birth weight, very low, and extremely low birth weight, are not gestationally age dependent. So they're just absolute numbers, okay? Symmetric IUGR generally represents intrinsic fetal abnormalities. Asymmetric IUGR generally is an extrinsic mother or placental issues. SGA outcomes, these are common outcomes in kids who are born small for gestational age. So it's useful to know those. We're going to talk a little bit about infants of diabetic mothers now. So etiology of IDMs. They have maternal hyperglycemia. We talked before about the fact that glucose freely crosses the placenta, so they become then fetally hyperglycemic. There's nothing wrong with the fetus's pancreas. So they get pancreatic beta cell hypertrophy, which ultimately leads to hyperinsulinism. So these kids are euglycemic at birth, but hyperinsulinemic. And they've been that way for a while. Because they lose their supply of glucose and because they don't glycogenolyze or gluconeogen, they don't break down glycogen to make glucose or make new glucose from other substrates, they get hypoglycemic at birth. They also have hyperinsulinemia, and that leads to fetal growth abnormalities because the insulin acts like growth factor. That's why they're called insulin-like growth factors. But here you have insulin being the culprit. And so these kids tend to get macrosomic. They have macro organ sizes. The ones that really get them in trouble are generally their hearts. They get increased glucose deposition as glycogen, which then can alter organ function. So if you've got a lot of glycogen in your lungs, you've got a further distance that your oxygen has to diffuse across, so it becomes more difficult for you to carry on normal respiratory function. So they can have abnormalities of a variety of different organs on the basis of their increased glycogen. Sudden fetal death is more common in infants of diabetic mothers, which is why they require increased fetal surveillance, felt to be due to a placental diffusion defect. And this is why many obstetricians these days don't let their diabetic moms go to term because of this issue of sudden fetal death. And so they'll tend to deliver them as they get closer to 38 or 39 weeks by inducing them. Macrosomia, they can get trauma or operative delivery issues. The infants who are IDMs have twice the amount of fat present after about 30 weeks. We talked about their glycogen and about their effects of insulin. Again, hypoglycemia, blood glucose less than 40. These children get into trouble with hypoglycemia in two different places, in two different stages. They have early hypoglycemia, which is generally minutes to hours after they're born. They can also get in trouble with late hypoglycemia, which is generally a day or so after they're born. So you have to be a little bit careful with these children and not just shunt them out to the normal newborn nursery without some sort of glucose surveillance. When they're hypoglycemic, they can present with lethargy, jitteriness, obviously with seizures if it gets low enough. So they need early and consistent glucose monitoring. They can also have hypocalcemia, which is felt to be a parathormone or a placental abnormality. Again, there is an issue of hypocalcemia and asphyxia. So kids who are modestly asphyxiated also have hypoglycemia. They can have accompanying hypophosphatemia and hypomagnesemia. How do you know? You have to look. Hyperbilirubinemia in infants of diabetic mothers. Why? Because of those. They tend to have polycythemia, about 20% of them. Polycythemia in and of itself can cause hyperbilirubinemia, or it can cause hyperviscosity syndrome. Hyperviscosity syndrome is when you got too many red cells and you start to sludge your blood, and it occurs with hematocrits that are greater than 70% monitored or obtained centrally. So not from a heel stick, from an actual draw with a needle in a vein. 70 is the magic number. Infants of diabetic mothers can also have RDS. So RDS doesn't just happen in preterm babies. It can happen in term babies as well. About 10% of IDMs will have some form of RDS. And there is an abnormal or an interfering effect of insulin on surfactant function. Infants of diabetic mothers can have congenital anomalies. We talked about early glucose control. The pathognomonic abnormality that they have in terms of congenital anomalies is caudal regression syndrome. So you have a baby described on a test question with caudal regression syndrome and are asked for what likely etiology is. It's an infant of a diabetic mother. They can also have these other abnormalities. They have an increased incidence of later obesity, and they themselves can have an increased incidence of diabetes, but the increased incidence of diabetes doesn't come in infants of diabetic mothers. It comes from infants of diabetic fathers. So, take that. All right, we're going to go through neonatal respiratory diseases, hyaline membrane disease, respiratory distress syndrome. Hyaline membrane disease is a pathological diagnosis. Pathological means you're dead. So this is generally not something to ascribe to a living child. Respiratory distress syndrome is the clinical presentation of hyaline membrane disease. It's common. Its incidence decreases with advancing gestational age. So much more common preterm versus term, and felt to be an abnormality of surfactant distribution and function. That's what surfactant is, dipalmitoyl phosphatidylcholine. It's also associated, the surfactant has apoproteins, phosphatidylglycerol, cholesterol. It's made by the type 2 alveolar cells, and its levels generally mature if you don't muck around with it at greater than 35 weeks gestation. This, by the way, is a fascinating story for a cocktail story, but I won't tell it to you now. But it took a long time for people to figure out that those proteins that they always isolated with surfactant from lung mush were actually important to surfactant function. Risk factors for respiratory distress syndrome, those are them. These are people who probably have genetic abnormalities of surfactant, either function or distribution or composition. What improves the outcome of respiratory distress in infants? If your mother was hypertensive, if she had premature rupture of membranes, if she had subacute placental abruption, or if she used narcotics. Not necessarily things we would ask them to do clinically. The lecithin-sphingomyelin ratio is a laboratory test that can help predict kids that are either at increased or decreased risk for RDS, and a level greater than 2 predicts mature surfactant function. These days, people also look at phosphatidylglycerol levels, and those generally mature after 34 weeks of gestation. So those are tests that can help predict the occurrence of respiratory distress syndrome. Antenatal steroids, that's what they do. No one has the slightest clue how they work. So when they start invoking different mechanisms and move their hands, when you see a neonatologist start going like this, they don't have the slightest idea what the hell's going on. In this country, we use predominantly betamethasone. In other countries, they use dexamethasone. One of the things that we should be careful about is multiple courses. So greater than 3 courses are associated with growth retardation, also brain maldevelopment. Respiratory distress generally presents within hours. Natural course, which no one sees anymore, is 3 days. But the important component here is that diuresis predicts recovery. So they'll give you a test question of a kid with respiratory distress syndrome, and they'll say that the child's urine output now increases to 3 or 4 mLs per kilo per hour. What can you expect? You can expect that the kid's going to recover from his RDS. Complications of RDS are generally the complications of prematurity. We talked a little bit about these. Chronic lung disease, patent ductus arteriosus, but in a child with respiratory distress syndrome, the duct generally shunts left to right, not right to left. So kids with persistent pulmonary hypertension, they right to left shunt. Kids with RDS or prematurity, they tend to left to right shunt. And intraventricular hemorrhages, again, for reasons that we don't understand. Diagnosis, based on signs and symptoms. The one thing that I want to focus your attention on is that they use this term ground glass appearance. If you see a test question that says a radiograph shows diffuse haziness and ground glass appearance, that baby has respiratory distress syndrome. Blood gases are characterized by increased CO2, low O2, and acidotic. The differential diagnosis generally is one of sepsis and pneumonia. If you're a neonatologist, sepsis is always second on your list for anything. Like, baby abnormal cry, septic. Mother cute, septic. Congenital heart disease is also on the differential diagnosis for respiratory distress syndrome. Surfactant replacement. These days, nobody uses synthetic surfactant except if you live in San Francisco, where all sorts of crazy stuff happens. So these are all either, they're naturally based surfactants from cows or pigs or whatever your animal of choice is. And it's given generally one of 2 ways, prophylactically or Treatment of established disease, that's important to know. So prophylaxis generally given to infants who are of younger gestational age. Prophylaxis is good because it better distributes inside the lungs. The problem with prophylaxis is that if you give it to everybody less than 28 weeks, the incidence of RDS is not 100% at 28 weeks. It's about 60 or 70%. So you will include normal infants if you give it that way. So therefore, it's much more costly. Treatment, if you give it to those children who only express the disease, only exposes those kids to the disease. But the problem is that the surfactant distributes more poorly in the lung and generally requires multiple doses. It's important to remember about supportive care for RDS. So these are some things that you should also think about. Here the issue is thermoregulation as well as fluid and glucose support. Okay? These days, we tend to use more continuous positive airway pressure or CPAP, particularly bubble CPAP, than we do with mechanical ventilation. We think it's the mechanical ventilation that's associated with the increased incidence of chronic lung disease in these babies, and so we tend not to intubate them unless we have to, and not to give them artificial respirations unless they don't have any respiratory effort on their own, and then trying to extubate them to CPAP as quickly as possible. So CPAP these days is the mainstay of mechanical ventilation for kids with respiratory distress syndrome. The idea behind mechanical ventilation is, and these are the words in quotes that you need to know, minimize volume trauma. So the tidal volume in a preterm kid is about 4 mLs per kilo. So generally, they're given very small tidal volumes. And to allow permissive hypercapnia. This is somewhat counterintuitive because the sicker the child is, the more likely we are to tolerate higher CO2s in that child. So you tend to want to blow those kids down because they have very high CO2s. But this whole idea of permissive hypercapnia, although I like the permissiveness of it, I allow you. It's kind of kingly. Yes, I allow you to have hypercapnia. And then the whole issue of high-frequency ventilation. The only thing you need to know about high-frequency ventilation is that it exists and that there are 3 ways that we give it: oscillating it, jetting it, or occluding it. So, a question might be, respiratory distress syndrome, A, only occurs in preterms, B, can be prevented through the use of antenatal maternal steroids, C, is cured following surfactant administration, D, generally limited to males, E, none of the above. Yeah, it's not prevented through the use of antenatal maternal steroids, but it's certainly, the incidence is decreased. Transient tachypnea of the newborn. The most important thing you need to know about transient tachypnea of the newborn is in its name. Number 1, transient. Number 2, it has to be tachypnea. 3, have to be a newborn. Therefore, this is a diagnosis made in arrears. You cannot walk into the nursery and say, aha, you have transient tachypnea of the newborn. Because you don't know if it's transient at that point, unless you're omniscient. Felt to be due to retained lung fluid. The old word for this is type 2 RDS, which I've never heard, or persistent postnatal pulmonary edema. Say that 3 times fast. So these are the features of transient tachypnea lungs. More common in terms, more common in males, particularly who have unlabored. So the classic kid who has transient tachypnea of the newborn is a boy born by elective cesarean delivery. The critical component of their clinical exam is that they don't have very much increased work of breathing. So these are kids who are tachypnic, but they're not grunting, they're not retracting, they don't have nasal flaring, they just are tachypnic. Their chest x-rays have hazy fluid, but notice no reticulogranular or infiltrate, and they're generally treated with oxygen or time. Persistent pulmonary hypertension we talked a little bit about. Remember that it's a syndrome, so it has multiple etiologies. We tend to think about it in terms of meconium, but you can have persistent pulmonary hypertension that's idiopathic or occurs from other reasons. So there are the other reasons. That's the one that tends to get the most interest going on people. So the problem is if you have pulmonary hypoplasia, you may not recover from your persistent pulmonary hypertension. And it certainly can be idiopathic. So this is a quick review here. This is a maintained pulmonary hypertension with right to left fetal shunts at the foramen and the ductal level. They have refractory hypoxemia. So no matter what you do, they're hypoxic. And one of the critical keys to their diagnosis is label cyanosis. These are kids who are puffing around in the nursery, and you look at them cross-eyed, and they drop their SATs to 12, followed by expletives. And like, I didn't do anything. Why are you doing that? So this is how one makes the diagnosis. And ultimately, obviously, it's made via echocardiography. Treatment is the treatment of underlying causes, and some attempt to try and dilate the pulmonary vessels, and the sexy way to do that these days is with inhaled nitric oxide. Why inhaled? Because hemoglobin inactivates nitric oxide. So if you try and give it any other way, it never gets to the lungs. And the cool thing is that if you give it in the lungs, the nitric oxide gets inactivated by the blood, and so it doesn't reach other organs and cause problems as well. So the attempt is to try and dilate pulmonary vessels or decrease pulmonary vascular resistance. It's a smooth muscle relaxant, and again, inhalation confines its effects to the lungs. The problem is that it's a very potent oxidant, so it tends to form free radicals. Free radicals! And also cause methemoglobinemia. And obviously, the bad complication of pulmonary hypertension is the need for ECMO. Other neonatal pulmonary diseases, pulmonary meconium aspiration syndrome. Many kids with meconium aspiration syndrome have aspirated antenatally. So that's what's sort of gotten us out of intubating in the delivery room. The only times we intubate kids from meconium in the delivery room now are if they're cyanotic or limp or don't have very good tone. Crying children probably should never have been intubated to begin with. Although I, as a stalwart member of the neonatology fraternity, am here to tell you now that residents graduate their residency with no freaking idea of how to intubate a baby anymore, because we don't do it. Meconium aspiration syndrome, amniome fusion while they're still fetuses, nasopharyngeal suctioning, and then endotracheal suctioning according to the AAP guidelines, which essentially said the kid has to be relatively moribund in order for you to put a tube down them and suck out their trachea. And again, this is all in acknowledgement of the fact that many of these kids have antenatally aspirated, and no amount of tracheal suctioning makes them any different. So in order to have meconium aspiration syndrome, folks, the diagnosis requires, one, you would be surprised how often this occurs. Where is the meconium? Oh, man. I knew something was wrong here. These children have patchy infiltrates, so they're not diffuse, and they commonly have an air leak. This is how you treat them, so that makes sense, huh? Try and reverse their hypoxemia and acidosis. And again, be careful about mechanical ventilation and air leaks. Surfactant is useful because meconium actually deactivates surfactant. And antibiotics, if the baby is septic, then antibiotics are useful, but generally meconium is sterile. So they have a chemical pneumonitis, not a bacterial pneumonitis. So, meconium aspiration, invariably, how's that for a word, leads to pulmonary hypertension, can be prevented via careful tracheal suctioning. Someone's going to have a problem with that. Is caused by bacteria found in fetal stool, can occur antenatally. Some people are getting bored because they're not playing anymore. Air leak, about 1% of kids are born with a pneumothorax or develop a pneumothorax. About 1/4% have pneumomediastinums. You have asymptomatic versus symptomatic disease. The diagnosis is generally based on a chest x-ray along with those clinical signs. And how do we treat it? The first thing is to cause no harm here. So we don't necessarily have to surgically decompress or interventionally decompress every pneumothorax that's out there. So many people will use the wait and watch method, particularly if the only sign or symptom that they have is tachypnea, or it was somehow revealed on a chest x-ray that was being done for some other reason. So you don't have to decompress all of them. The simplest way is to do a needle aspiration, which is where you put a small needle into the pleural space and decompress them, because many of them won't recur. And then recurrent pneumothoraces generally need a chest tube. I would not suggest that you go chasing a pneumomediastinum. This is not in your pay grade. And it is not in my pay grade either. Hello, cardiology. They love to put needles in spots where they shouldn't, so they're happy with that. Pulmonary hemorrhage is actually common. It's not unusual to get some blood-tinged suctioning material. Happens more frequently in preterms. Can be associated with asphyxia or a bleeding diathesis, but is much more common after surfactant administration. So this is another reason to perhaps not give prophylactic surfactant, because you'll have some kids that have a pulmonary bleed who never had RDS. Interstitial pulmonary fibrosis. This is a disease that lives only on the test. So-called Mickey-Wilson syndrome. So I think they call it more interstitial pulmonary fibrosis now. This happens in preterms with no respiratory distress syndrome and generally has onset at the first month. So this, if you will, don't tell anybody I told you this, is like BPD without RDS. So it's the same process of disease mechanism, but these children never had RDS. I'm here to tell you I've never made this diagnosis, but the test makes the diagnosis. So interstitial pulmonary fibrosis, Mickey-Wilson syndrome, or Wilson-Mickey if you're a Wilson fan. The critical component is that these babies never had RDS. So their chest x-rays look just like kids with bronchopulmonary dysplasia. Pneumonia, most commonly bacterial pneumonia, is group B strep. So this generally, group B strep comes in two flavors, early and late onset. Early onset's more common. Generally, early onset's associated with pneumonia and sepsis. Late onset group B strep disease is associated with sepsis meningitis. Prophylaxis of group B strep is only effective against early onset disease. So don't rule out a 4-week-old who comes in with sepsis on the basis of the fact that his mother received intrapartum prophylaxis. So this is how you get it. Generally early, they present on the first or second days. Again, we don't generally use latex agglutination anymore because of the high incidence of false positives. And they generally present not with leukocytosis, but generally with leukopenia. So if the only way you treat your kids for presumed sepsis is if they have a high white count, you'll miss the kids who have group B strep sepsis, which they may be upset about. So these are more discussion about the preventative guidelines. This you have in your notes. And here's a little pathway for people who like pathway. I think the issue here is, let's start here. Pregnant women treated for group B strep. Is the neonate septic? So if you're symptomatic, no matter what happened to your mother, you need to be worked up. That sounds straightforward? All right. If you're preterm, then you probably deserve a limited workup. If the antibiotics have been given greater than 4 hours before delivery, you're okay. But less than 4 hours, you probably deserve a workup. And the other thing the Academy is going to be upset about is this right here. Observe at least 48 hours. So these are not kids who go home on the first day of life. Okay? So, sick, culture, and treat pending cultures. Well, if you're term, you've had prophylaxis less than 4 hours, you need prolonged observation. If you've had prophylaxis greater than 4 hours, you have no issues. If you're preterm, consider a CBC and a culture. Treatment, there you go. We generally treat pneumonia and meningitis longer than we treat sepsis. We're going to talk real briefly about circulatory congenital heart disease and talk about the 5 terrible T's. Transposition, tricuspid atresia, truncus, tetralogy, total anomalous pulmonary venous return. These are the causes of cyanotic congenital heart disease in the newborn. They will just ask you those disease states. So you need to know that those are the 5 things that are associated with cyanotic heart disease. The 3 bad left-sided heart lesions are hypoplastic left heart, coarctation of the aorta, and severe aortic stenosis. The more common anomalies are ASDs, VSDs, and patent ductuses. And again, depending on when you ask the question, everybody's got a patent ductus. How do you make the diagnosis of patent ductus? This is the classic way. Continuous murmur, so a murmur that extends past systole. Hyperdynamic precordium, bounding pulses. Eventually, because they start to flood their lungs, they get worsening pulmonary pressure, pulmonary function, and they have wide pulse pressures. That's not the same thing as a mean pressure. A pulse pressure is the difference between systolic and diastolic, and generally greater than 20 torr, 20 millimeters of mercury, is a widened pulse pressure. Why is it wide? Because at the end of systole, the blood just keeps running into the ductus. So there isn't anything to establish a bottom floor in diastole. So the blood just keeps running into the pulmonary circulation until systole occurs again. Treatment these days, ligation and indomethacin. Indomethacin is a prostaglandin synthase inhibitor. The problem with indomethacin is that it can cause oligouria. The problem with ligation is that the surgeon can ligate the wrong thing. Indomethacin is also associated with intestinal perforation. So you need to know those complications, oligouria, and intestinal perforation with the use of indomethacin. So we talked before about meconium plugs. They occur generally in the distal colon or the anal rectal region. They cause obstruction. They can ultimately cause ulceration and perforation. And the isotonic saline or gastrographin enema can be both diagnostic and therapeutic. Diagnostic in that it will show the obstruction, therapeutic in that it often relieves the obstruction. It can cause or be associated with small left colon syndrome, hypothyroidism, Hirschsprung's, can be associated with maternal drug abuse or prolonged mag sulfate in women who have had PIH. And again, here's this little cystic fibrosis issue. Meconium ileus. Meconium ileus is generally a lower intestinal obstruction, so not quite as distal as a meconium plug. It can be associated with atresia volvulus or perforation. And between you and me, this is the disease that actually is associated with cystic fibrosis. Okay? But both of them, according to the Academy. Have I said that enough? Thank you. I'll stop. The clinical features of meconium ileus are doughy abdomen. Gastrographin enema will often show multiple fibrotic sites. And they can have meconium peritonitis, which is a funny thing if you actually see it on an X-ray. It's an abdominal X-ray that shows intra-abdominal calcifications. So what has happened is that the perforation occurred antenatally and has healed over, and the meconium is actually calcified in the abdominal cavity. So intra-abdominal calcifications are a sign of meconium ileus. Necrotizing enterocolitis is an inflammatory bowel lesion, typically in the ileocecal region for reasons that no one really understands, and typically occurs in preterm infants because of the issues of developing bowel, the role of feeding, so generally either free air portal air, which is air in the portal circulation, so linear streaks of gas in the substance of the liver, or this thing called pneumatosis intestinalis. That's the pathognomonic find of necrotizing enterocolitis. And what is it? It's air in the bowel wall. Again, they tend not to show you pictures of this stuff, which is why I didn't show you pictures. They tend to use these terms. So pneumatosis intestinalis is air in the bowel wall that's associated with the diagnosis of necrotizing enterocolitis. Treatment, generally early, is medical. So we generally don't feed them, decompress them, give them antibiotics. But ultimately, if they're perfed, they need surgery. And now we're going to finish this with a discussion of hyperbilirubinemia. So jaundice. Jaundice is the deposition of bilirubin in your skin or in the sclera of your eyes. It's very common in newborns. Why? For lots of different reasons, but newborn red blood cell walls are much more fragile than yours or mine, so they have fragile red blood cells. They tend to be born with high crits, so their hemoglobin low. They have decreased bilirubin clearance because of abnormal, well, because of immature, let's put it that way, liver function. So it's common in newborns. This is the pathway for the generation of bilirubin. Thanks. Jeez, I hate when that happens. So you start with hemoglobin. Hemoglobin is then broken down into a compound called biliverdin, VER, plus carbon monoxide. And in fact, people have used the exhaled amount of carbon monoxide as an adjunct to deciding which kids are hemolyzing quickly versus hemolyzing slowly. Biliverdin is actually an interesting compound because biliverdin is not toxic. It's water-soluble, very easily excreted. It's the stuff that makes your windshield green when a bird poops on it. And in fact, mammals are the only species that actually take a non-toxic substance, biliverdin, and convert it into a toxic substance, bilirubin. So one might ask, what was God's plan here? And the answer is, it's a very potent, bilirubin is a very potent antioxidant. So there's probably a protective effect of bilirubin. This is a long way of explaining that all hyperbilirubinemia should probably not be treated. And that a little hyperbilirubinemia is actually good for your soul. So, there you have it. So the bilirubin is then glucuronidated, so bilirubin is insoluble in water. It gets glucuronidated in the liver, which then allows it to be water-soluble, and then ultimately excreted. So the glucuronidated bilirubin is called conjugated bilirubin. It's bilirubin that's been conjugated to glucuronide. And it's the direct reacting bilirubin. Direct because it's water soluble and you don't have to add another reagent to the test tube in order to be able to figure out what the level is. So it directly reacts with your reagents. So it's the water soluble, direct reacting form of bilirubin versus the unconjugated bilirubin, which is only lipid soluble, not water soluble, unconjugated, and indirectly reacts in the test tube because you got to add another reagent to solubilize it. So direct reacting, soluble, conjugated, indirect reacting, insoluble in water, unconjugated. Generally, we don't measure the indirect component, we calculate it. So the total bilirubin minus the conjugated bilirubin is thought to be the indirect bilirubin. You may use that thought everywhere except in the presence of a hepatologist, because it turns out that the indirect bilirubin comes from other places too. So they freak out a little bit. But since they are not administering the test, as far as the test is concerned, the total minus the conjugated gives you the indirect fraction of bilirubin. So what's the pathology? Either a combination or an overabundance of either overproduction of bilirubin or reduced clearance of bilirubin. So what about on the overproduction side? The major cause of overproduction is hemolysis, and hemolysis can either be immune-mediated, so those are the ABO-RH incompatibilities, or non-immune-mediated. Those are generally the cell wall or hemoglobinopathies that are unstable that cause hemolysis. So overproduction, hemolysis either immune or non-immune mediated. What about the other non-immune mediated? Enzyme deficiencies, so those are the cell wall abnormalities, G6PD or pyruvate kinase deficiency, or structural defects of the cell wall like hereditary spherocytosis. So hemolysis, immune-mediated blood group incompatibilities, non-immune-mediated cell wall hemoglobinopathies, structural defects. What about the decreased clearance side? So increased production, we just talked about, decreased clearance. Impaired conjugation, so breast milk jaundice. Breast milk has a steroid compound that directly influences the ability of the liver to be able to conjugate bilirubin. So breast milk jaundice is a cause of impaired conjugation. It can also happen in preterms because their liver function isn't normal yet. You can have decreased hepatic uptake of bilirubin. Those are your Gilberts and your Kriegler-Najars. So people's names are decreased hepatic uptake. Or you can have increased enterohepatic recirculation, where the stuff gets conjugated, excreted into the bowel, but then deconjugated, generally by bacterial flora in the bowel, and reuptake back into the circulation. So enterohepatic recirculation, either from obstruction, so you've got bad transit times and the stuff just sits around, or by some sort of feeding intolerance that allows enterohepatic recirculation to occur. What about the timing of jaundice? This will be on the test. Jaundice that occurs in the first 24 hours of life should be considered always to be pathologic. The more common cause of jaundice on the second and third are physiologic jaundice or sepsis. Jaundice that occurs within the first week or towards the end of the first week is breast milk jaundice generally. And then the other big one that people want you to remember, so the first one is first day jaundice, pathologic. Second one is jaundice that occurs late after the third week is biliary atresia. And the test really focuses on biliary atresia. So how do we work up kids with jaundice? The first is the interpretation of results varies with their postnatal age. What the hell do I mean by that? If you are born at 11:59 p.m. at 1 o'clock in the morning the next day, how many days old are you? 1. Sorry. If you are born at 1 o'clock in the morning, how long does it take you to get to be 1 day old? 23 hours. So all 1 day olds are not created equal. And this carries on for the next couple of days. So interpreting bilirubin values is important, and you need to consider how old the child is. And those nomograms that you see, the Butani nomograms, on the horizontal axis is not days of life like it used to be, it's hours of life. And so it's important for you to be able to know how old the child was, because the tolerance of the bilirubin level changes as a function of postnatal age in hours. Okay? So what we need when we're working up babies is some sort of idea about how old they are. And 1 day is not the right answer. You need to know what their total and their direct bilirubins are. At the minimum, if the mother is O or Rh negative, you need a Coombs test. And in a perfect world, you get a peripheral smear. But again, these can be difficult after 4 o'clock in the afternoon on a Tuesday. What about therapy? So again, the Butani nomograms It's good to be famous for something, isn't it? You got Downs, you got Butani. The Butani nomogram does two things. There are two different ones. The first Butani nomogram takes the level of bilirubin, and actually it's total bilirubin, even though it's the unconjugated bilirubin that's toxic. They don't do the nomogram in terms of unconjugated. They do it in terms of total. So it's the total bilirubin versus the hours of age. And the most typical therapy is generally phototherapy. And what do you need to know about phototherapy for the exam? You need to know that the form of bilirubin that's created in response to light is called lumirubin. That's not too tough. And that the efficacy of phototherapy is dependent on three things. It's the type of the light, it's the area that's exposed, and it's the distance of the light source to the baby. The blue or blue-green wavelengths are the most efficacious, so the small wavelengths of light, okay? The problem with blue and blue-green wavelengths is that if you are a normal person working in that environment, it generally makes you ill. So nurses do not like the blue or blue-green. So what they have are white, quote, white lights that are pushed into the blue-green spectrum. They're generally special phototherapy bulbs. This has nothing to do with the exam at this point, but I'm here as an evangelist. The reason I'm here as the evangelist is that special Billy bulbs throw out a light that looks exactly like every other fluorescent light on the country. And if your medical people, the medical equipment people don't know that, the first time the equipment goes down to have its light bulbs changed, they come back with the wrong fluorescent bulbs in it. So you want to be a hero in your nursery? Walk over to the light fixture that gives the phototherapy if they're fluorescent bulbs, and look at the end of the bulb. The beginning of the number should have two B's in front of it, BB, for bilirubin something or another. I don't remember what the other B's for. Bilirubin blue, I think. If they don't have BB, they're the wrong light bulbs. Be a hero. Okay, enough evangelizing. So blue-green light is the most efficacious, but most people use light that's slanted towards the blue-green spectrum. The area of the baby exposed. This is one of the more appropriate things that we should talk about. I had a woman come back for follow-up for her hyperbilirubin, a kid who had the diaper, her clothes, her coat, and the bilirubin blanket on the back. Obviously, we hadn't done a good job explaining to this woman how the damn thing worked. So the more of the baby you can get exposed, the more efficacious it is. And so no T-shirts, no caps, no blankets, no nothing. And then if you're really in trouble, you can stick a blanket underneath the kid and use overhead phototherapy and get as much area exposed as you can. Standard versus fiber optic, I mean, part of it depends. Oh, distance to the baby. So the distance to the baby squared decreases the efficacy of the phototherapy. So the further away the light source, the less it works. You cannot overdose babies on phototherapy. So what you can do, though, is cook them. Medium rare? It's not tolerated well. So again, cool phototherapy versus hot phototherapy. The ones that really get you in trouble are those quartz overhead lights because they are hot. But generally the fluorescent bulbs are pretty well tolerated, and certainly the cool phototherapy, the blankets are certainly very well tolerated. The only problem with fiber optic phototherapy is that it's expensive. Complications of phototherapy. So some kids will get diarrhea, and I'm not exactly sure how that works, but these are kids that you're already watching for insensible loss, right, because you've got them lit up. So you have to be careful about fluid intake in these kids. And generally, we encourage these kids to continue breastfeeding because that is going to shorten the transit time of their gut. And so if you don't want to run into enterohepatic recirculation, the more you feed these kids, the better off they are. There are some old people around who believe in the fact that eclipses cause congenital birth defects and that somehow feeding babies with hyperbilirubinemia will make them worse. There's no evidence that overhydration protects a kid from anything except more diapers. So overhydrating these kids doesn't get you anywhere. So best to let them keep feeding. The only problem with feeding is they come off the phototherapy. So generally, again, a billy blanket can be useful for these kids. So complications of the phototherapy are relatively limited, generally associated with heat, and sometimes they can have GI upset. Double volume exchange transfusions is what to do if the phototherapy isn't working. The kinds of issues that kids have with double volume exchange transfusions, this is what the test will wonder about, even though you're not likely to do a double volume exchange transfusion in your life. And I don't even remember the last time I did one. Hypocalcemia, thrombocytopenia, catheter-related issues, necrotizing enterocolitis, and if you're dumb enough not to irradiate the blood, graft versus host disease. So there will be a question about the complications of double volume exchange transfusions. Erythroblastosis fetalis, this is going to wrap this up for us, is a hemolytic disease of the newborn that's associated with Rh antigens. Generally what happens is that there's escape of fetal blood into the maternal compartment. She gets sensitized, starts to make antibodies against the Rh antigen, generally D, and the baby gets hemolysis. The way that it generally progresses is that it gets worse with subsequent pregnancies because essentially she's being re-immunized against the antigen. It can lead to hydrops. It's associated with infant hyperinsulinism. So in many ways, these erythroblastotic babies act like infants of diabetic mothers. And it can be prevented with RhoGAM, which is purified antibody against the Rh antigens that's given to the mother. So how does it work? It works by the fact that it seeks out and destroys the Rh positive cells that are going to elicit the immune response in the mother before she can do that. And so generally it's given some antenatally and some postnatally in association with her history of being exposed. So you can be exposed antenatally and at the time of delivery, although time of delivery is generally the most common. What is kernicterus? Kernicterus is one of the dreaded outcomes of hyperbilirubinemia. It's bilirubin staining of the basal ganglia of the brain. That's the definition of kernicterus. So again, it's a pathological diagnosis, not a clinical diagnosis. So the only way you can make the diagnosis of kernicterus is with a slide and a microscope. The clinical syndrome is called bilirubin encephalopathy, and it's generally associated with hypotonia or hypertonia, deafness, and motor deficit, so cerebral palsy and deafness. Here's an audience response question that may be the last thing I talk to you about. Neonatal jaundice is always physiologic in the first few days of life, can be accurately estimated by physical exam, is associated with long-term sequelae only if exceeding 25 milligrams per deciliter, and must be evaluated in association with postnatal age. Oh, now nobody's playing. Come on. Oh, there you go. Thank you.